My name is Xinwei Wang. I'm the co-director for the NCI Liver Cancer Program. And on behalf of my colleagues, Tim Gretton and Anu Buddha, we would like to welcome all of you for attending our second monthly seminar series of this year, 2024. This year's seminar, we're gonna have a very distinguished physician scientist, Dr. Amy Singas, who will give us a talk. A few words about Amy. So Dr. Singa received his medical degrees at the University of Michigan. So go blue.
Go blue.
He completed his residency in internal medicine at the University of Washington and then received additional training in gastroenterology and transplant hepatology through separate fellowship at the University of Michigan. He also holds master's degrees in health and healthcare research and clinical science with distinction from the University of Michigan as well. Currently, Amy is the professor of medicine at the UT Southwest Medical Center and serves as the chief of hepatology and medical director of the liver tumor program. Now, his research is focusing on liver cancer care in a large an area, including prevention, screening, and early detection and treatment for survivorship for the people who suffer from liver cancer, which is the topic that really dear our heart from the liver cancer program. And his work is funded by the NCI as well as Cancer Research and Research Institute of Texas. He has over 300 peer-reviewed original publications, and such as JAMA, Gastroenterology, Hepatology, and Journal Hepatology, and the Gut, and many other outstanding journals. And above this, Amy also has many accolades, and including I would say listed here is a Wells Madrid Distinguished Chair in Liver Disease and the Blue Ferris Award for Excellence of Liver Cancer Research. Today, he will be discuss early detection of liver cancer, particularly hepatocellular carcinoma, the current status, and the future directions. Without further ado, let's welcome Dr. Singa.
Thanks, Zin, for that kind introduction, and thank you for the program to invite me here today to give this talk. As you heard, I'll be speaking on a topic that's near and dear to the NCI as well as myself in terms of early detection of hepatocellular carcinoma, both its current status and some of my thoughts in terms of future directions. Here you can see my disclosures. So to start, I think something that doesn't come of a surprise to anyone on this call is that HCC is clearly a cancer that we need to do better. So it's the third leading cause of cancer-related death worldwide, with the highest burden in East Asia and in Africa. In the United States and many parts of Europe, it has more of an intermediate incidence and mortality rate, although it remains a cancer where the 5-year survival still remains around 20%. And it remains a cancer where the mortality rate continues to increase, suggesting that we need to do better for this cancer. When we take a look at the high HCC-related mortality, I think this can be attributed to failures at multiple steps in the cancer care continuum. I think, of course, we can attribute this to sort of insufficient performance of palliative therapies, although we've seen notable advances in terms of our systemic therapies for HCC with the introduction of immune checkpoint inhibitors. But from a care process perspective, we've seen failures along the entire cancer care continuum, which has been adopted and sort of evaluated across many different cancer types. Here we can see the cancer care continuum tailored to HCC, and we see multiple different steps, including risk assessment, early detection, follow-up, timely diagnosis, and timely treatment. And there have been studies that show failures, once again, at each of these different steps. Failure to identify at-risk patients, suboptimal screening among at-risk patients, delayed follow-up, delayed diagnostic testing, and then finally delayed treatment, as well as underuse of curative therapies for patients found at an early stage. Now, for purposes of today's talk, I'm really going to be focused on the first two steps here, risk stratification and early detection, For the vast majority, I'll be focusing on early detection, although I will spend a few minutes on risk stratification to start. And I think, once again, this is probably the most important point. It goes back to that Ben Franklin adage, an ounce of prevention is worth a pound of cure, that if we can find these patients at an early stage and implement either primary prevention or secondary prevention, i.e. early detection, we can actually do much more than if we focus on patients with large tumor burden in terms of applying systemic therapies. We can see here a schematic of the Barcelona Clinic liver cancer staging and treatment allocation system, where we see those patients found at an early stage are amenable to curative therapies, local ablation, surgical resection, liver transplantation, and we see a median survival well over 5 years. Once again, even though we've seen tremendous advances in terms of systemic therapies that have generated a lot of excitement, it's noteworthy that the median survival for these patients still is 1.5 to 2 years at best. And so really, once again, the biggest bang for our buck, our biggest ROI, can be promoting and optimizing early detection of patients with HCC. Now, once again, a concept that I think many in the room are familiar with, but I just want to spend a minute sort of reviewing the difference between risk stratification and early detection. So risk stratification takes our at-risk state, which in this case is primarily in the Western world patients with cirrhosis, although there are globally, obviously, a large proportion of patients who have chronic hepatitis B in a non-cirrhotic state. And it further takes these patients without any evidence of HCC and is able to stratify them in terms of high risk versus lower risk. In contrast, early detection biomarkers are much more proximal, much more closely related to the state of having HCC, where the goal is to detect subclinical HCC. So these are patients who have HCC, but are not symptomatic, are not clinically detectable, and it's using measures, whether sort of blood-based or imaging-based, to detect them at an asymptomatic early stage, where once again, we have curative therapies available. Now, I'll come back to this at the end of the talk, these two steps are critical if we want to move beyond our current one-size-fits-all strategy to more of a precision screening strategy. And I think when you take a look at the future direction, which I'll come back to at the end, this is really where we want to take HCC surveillance. As I'll reference later on, we currently have a one-size-fits-all where we take all patients with cirrhosis and all these high-risk hepatitis B patients, and we put them through a similar strategy of ultrasound plus AFP. We don't consider truly risk stratification, and we don't consider the multitude of surveillance strategies which are coming to market to think through how we can tailor these to individual patients in front of us. And so this is really, once again, a vision of where we want to go in the future. So now, talking through each of these individual steps, let's talk about where we are with risk stratification. So as I referenced, guidelines currently recommend surveillance in high-risk individuals, although I would argue these are grossly defined at this point. We currently recommend surveillance in all patients with cirrhosis from any etiology, and that's because, in general, this group of patients has a sufficiently high risk of HCC for surveillance to be cost-effective. Similarly, we recommend surveillance in patients with chronic hepatitis B who are sufficiently high risk at a threshold of 0.2% per year. Now, we're doing better with hepatitis B than we are with cirrhosis in terms of considering risk stratification. And here we can see a table on the left-hand side that looks at the most recent AASLD guidelines from this past year. And you can see that clinical risk scores are now identified in the AASLD guidelines in terms of identifying these high-risk patients with hepatitis B using the PAGE B score and a score greater than 9, or score of 10 or greater. Now, there's a clear need for us to become more nuanced with our sort of at-risk populations. So for example, if we take one of the growing populations of at-risk patients, this would be patients with metabolic dysfunction-associated steatotic liver disease. These historically called non-alcoholic fatty liver disease. So we know from several cohort studies that there are a substantial proportion of patients who have underlying metabolic dysfunction associated steatotic liver disease who develop HCC in the absence of cirrhosis. Here we can see one such study from the National VA, which takes a look at the proportion of patients who do not have cirrhosis across several different etiologies. We can see that amongst other etiologies, hepatitis C, hepatitis B, alcohol use, less than 10% of patients develop HCC in the absence of cirrhosis. Now, if we take a look at patients who have underlying metabolic dysfunction associated steatotic liver disease, about 29% of patients have HCC in the absence of cirrhosis. Similarly, small number, but idiopathic, many of these patients having underlying MASLD also develop HCC in the absence of cirrhosis, really showing that this disease tends to be different than those patients with other etiologies. And so this, when first came to light, started to question if we needed to think through a broader at-risk populations. Do we need to do HCC surveillance in all patients with metabolic dysfunction associated liver disease? And this would be disastrous in a way for surveillance because 20 to 30% of Americans have some form of underlying MASLD. And so to do HCC surveillance in this large proportion of patients would be very, very difficult. Now, subsequently, there have been cohort studies taking a look at the annual incidence of HCC in these patients with non-cirrhotic MASLD. And so here, once again, we can see a follow-up study from the National VA taking a look at the annual risk of HCC in patients with cirrhosis versus the absence of cirrhosis. Those patients with MASLD cirrhosis had an annual risk of developing HCC of over 1%, i.e., passing the cost-effectiveness threshold for HCC surveillance. In contrast, those patients in the absence of cirrhosis had an annual incidence of 0.008. So very low annual risk of developing HCC. And so we can say with good sort of confidence currently that all patients with non-cirrhotic MASLD do not warrant HCC surveillance. However, it's clear that that isn't the answer either. We still need to do a better job of identifying these higher risk patients with non-cirrhotic MASLD who will develop HCC. And so this clearly is a population in need of better risk stratification. Similarly, we know that not all of these patients who are currently recommended to have surveillance are at equal risk. So on the left-hand side, we can see data actually supporting the PAGE-B score in patients with non-cirrhotic hepatitis B on antiviral therapy. And you can see that the PAGE-B score here nicely stratifies patients into low risk, intermediate risk, and high risk, with annual incidence varying from 0.7% all the way up to 18% over a 5-year period. And so this really highlights why we're able to advocate for these patients with higher risk to undergo HCC surveillance, whereas those patients who have lower risk don't warrant HCC surveillance given a low annual risk and HCC surveillance not being cost effective in these patient populations. Similarly, clinical risk scores have been developed in patients with cirrhosis from several different etiologies. I show you one such study looking at patients with MASLD cirrhosis in the VA cohort. And you can see that in this cohort, risk stratification scores using simple factors like age, sex, body mass index, diabetes, platelet count, albumin, and AST/ALT are able to stratify patients over time. You can see a low risk group, intermediate risk group, and high risk group. However, the C statistic for most of these clinical risk scores in patients with cirrhosis still are in that 0.7 to mid 0.7 range, and very few have been externally validated, which are important steps prior to routine use in clinical practice. So a lot of evaluation going on in this area, but I think that we need better data before we can use these risk scores to better identify which cirrhosis patients really need HCC surveillance and which patients may not require HCC surveillance at this time. Now, there has been a push to move beyond simple clinical scores. I mean, so, there have been a look at a couple different biomarkers I won't talk about ViraScan. I mean, Zin is sort of the sort of master of the ViraScan, and I mean, I'm sure has given a much more nuanced interpretation of ViraScan than I can. And so I think that, you know, I think that his evaluation of viral exposures and subsequent responses to those viral exposures is a very interesting phenomenon, which once again can accurately predict which patients may develop HCC, including amongst patients with cirrhosis. And so that by itself is an important biomarker that needs to move forward. And here we can see PL-seq-AFP, another risk stratification biomarker that has been proposed and evaluated by Yujin Hoshida, one of my colleagues at UT Southwestern, over the last couple of years. So PL-seq-AFP initially started as a prognostic liver secretome, a tissue-based biomarker that was published in New England Journal over 10 years ago. And that tissue-based biomarker among patients with cirrhosis was able to accurately predict who would develop HCC recurrence after a resection, as well as would develop incident HCC amongst patients with cirrhosis, validated in cohorts globally, and you know, in over thousands of patients. Although the tissue-based nature of that biomarker limited its widespread appeal as well as implementation in clinical practice. And so Yujin and his group worked for sort of, you know, many years to actually surrogate this in a blood-based biomarker. And this was successfully done just this past couple of years, where he identified PL-seq, the biomarker, which is a serum-based surrogate of this tissue-based biomarker, and combined this with AFP. So this biomarker was initially evaluated in a cohort of around 330 patients, of whom 46 developed HCC, and PL-seq was able to risk stratify patients accurately and able to do even better when it was combined with AFP. This has been subsequently evaluated in both the National HEADS cohort, a cohort funded by the Early Detection Research Network, as well as the Texas HCC cohort, a cohort funded by the Cancer Prevention Research Institute of Texas. Both of these cohorts are large, with over 1,500 patients each, and together, there have been 137 patients who have developed HCC in the Texas HCC cohort, and there have been over 100 patients who have developed HCC in the HEADS cohort. In both of these cohorts, PL-seq-AFP was able to accurately risk stratify patients in terms of risk of incident HCC, with death and liver transplant as competing outcomes. In the Texas HCC cohort, you can see the figures on the left-hand side, and you can see the adjusted hazard ratio between high risk and low risk patients was 2.6, which is important because this adjusted hazard ratio exceeds the threshold for cost effectiveness for a risk stratification biomarker. Notably, this biomarker outperformed traditional HCC risk scores like AMAP and the Toronto HCC Risk Index, and integrating these clinical risk scores with the biomarker was shown to be complementary. And on the bottom bullet point, you can see integrating PL-seq-AFP with AMAP was able to identify 3 groups, which you can accurately risk stratify patients into a high-risk group, annual HCC incidence around 7%, and in the low-risk group, a very low annual incidence of 0.4%. And this is notable because this annual incidence is below the cost effectiveness threshold for HCC surveillance. And it's arguable that you may be able to, instead of performing HCC surveillance, simply follow these patients with repeat risk assessment. So I start there in terms of risk assessment, in terms of really showing that there's a need for risk assessment. There have been clinical risk scores that have been proposed, although need further validation. And we're now starting to see exciting advances in terms of biomarkers that may help us in terms of risk assessment. So I think this is going to be a fast-moving field over the next couple of years where we're going to see advances that will better identify at-risk patients, both with and without cirrhosis. With the remaining time, I'd like to really focus on surveillance, early detection of HCC, i.e. the main focus of my talk today. So before I get into the nuances of emerging modalities and where I think the field is moving, I think it's worth reviewing the data that actually supports our current guidelines for HCC surveillance. So as many of you know, HCC surveillance is supported and endorsed by professional society guidelines from the American Association for the Study of Liver Disease, the European Association for the Study of Liver, the Asian Pacific guidelines for the study of the liver, the NCCN, the National VA. So we have multiple societies that endorse HCC surveillance. Notably, the USPSTF does not endorse HCC surveillance. And, we'll talk through some of those limitations of why that may be the case. But I think this also at least references why HCC surveillance is likely partly underused in clinical practice. And I hope something we can address through some of the work that is ongoing. So currently, some of the best data supporting HCC surveillance comes from a large randomized control trial that was published now 20 years ago from a cohort of patients who have chronic hepatitis B. You can see that patients were randomized to receive HCC surveillance using ultrasound plus AFP versus no surveillance. Notably, the patients who were randomized to surveillance had significantly higher proportions found at an early stage, significantly higher proportions that underwent curative therapy, and this remains our level 1 data showing that HCC surveillance reduces HCC-related mortality with a 37% reduction in HCC-related mortality in this randomized study. Now, of course, these data are internally valid. The question is, are they externally valid to the populations we see in our contemporary US practices? Now, I know you work at the NCI, and so I think there's a diversity of patients that you see. I work in Texas, so the body habitus on the right is almost uniformly the body habitus that I see in clinical practice. So in contrast to the sort of skinny population that was likely enrolled in the randomized trial in China in the 1990s, this is the contemporary cirrhosis population that we see often in the US now. Further, patients with hepatitis B often have a well-preserved liver where you see smooth liver contour. In contrast, in patients with cirrhosis, cirrhosis is defined by a shrunken nodular liver. And so the look for and the search for early HCC is a needle in a haystack. You're looking for a small nodule of HCC within multiple nodules of underlying cirrhosis. And so this task is much, much more difficult in our contemporary US populations. Now, when a large randomized trial for surveillance was attempted in Australia several years ago, the trial failed to enroll. Both patients and providers refused to enroll in the clinical trial. That was actually led to a publication in Hepatology, one of our lead journals, that actually said a trial of HCC surveillance is not feasible, nor may it be ethical. And so this has been dogma for the last decade plus, that a randomized trial of HCC surveillance is not feasible. And so we're forced to depend on cohort studies. And there have been several cohort studies that have looked at the benefits of HCC surveillance, and you can see the most recent cohort studies summarized in this systematic review and meta-analysis here. Now, there are several more cohort studies that have actually been published. Here you can see the subset of studies that have adjusted for some of the biases, including lead time bias. So here we can see the benefits of HCC surveillance from an overall survival perspective in the figure, with a hazard ratio of 0.67, a 33% improvement in survival after adjustment for lead time bias. Now, of course, this doesn't adjust fully for other biases. Very few of these adjust for length time bias. There's still the risk of residual confounding, given the fact that these are cohort studies. So I think all of us concede that these are imperfect data, although I think most of you would agree that the data consistently do suggest a benefit of HCC surveillance. There are also data that show consistent associations with early stage detection and receipt of curative therapy, with odds ratios of 1.9 and 1.8 respectively. Now, of course, when we think of overall value, benefits are only half of the equation. So we have to weigh these surveillance benefits against potential harms. These harms are defined as physical complications, psychological distress, and financial burden. And it's important that this not only must be evaluated on a programmatic basis, but also by clinical providers when they're approaching individual patients in front of us, in front of them, thinking how this balance of benefits and harms may differ for individual patients. Now, the easiest example here is thinking through things like age, comorbidity, but also from a surveillance perspective in patients with cirrhosis, one must think of underlying liver dysfunction, where we know that the benefits of surveillance are greater in patients with preserved liver function, Child-Pugh-A, than those patients with significant liver dysfunction, such as Child-Pugh-C. Now, the taxonomy of harms for cancer screening have been defined and should be consistently applied across cancers. So this isn't something that we define, but this is something that's been defined for us in terms of physical, financial, and psychological harms. Now, it's important to note that these harms can be related to the screening tests themselves, but also may be related to follow-up testing, and it extends beyond complications and may include things like simple discomfort, indirect costs of missing work, or simple anticipation and anxiety about having abnormal screening results. And so it's important that we measure all of these different harms and not ignore them, and then on the back end, apply severity, whether this is mild, moderate, or severe. But it's important that we think through this from a global perspective. Now, like many cancers, the preponderance of data has focused on benefits, and there's a dearth of data looking at these harms. So when you take a look at the studies looking at benefits, there are several. There are sort of double-digit studies that have looked at surveillance benefits for HCC. In contrast, there have been a totality of 4 studies that looked at surveillance harms from a physical harms perspective. There were no data until recently on financial or psychological harms. In terms of the data for surveillance harms across the 4 studies, you can see data broken out for one of the studies that we conducted, which was conducted in a retrospective cohort of nearly 700 patients with cirrhosis, followed for a period of 3 years. In this cohort, when we take a look at the benefits, there were 48 patients who developed HCC, 34 who were found at an early stage. And so those were the patients that we defined as having a benefit of HCC surveillance, those 34 patients who were found at an early stage. In contrast, physical harms were observed in 187 patients, 28% of the cohort. Physical harms being defined here as diagnostic evaluation for a false positive or indeterminate result. Now, it's notable that the diagnostic evaluation in HCC is a simple CT scan and MRI for most patients. In contrast to prostate cancer screening, where that harm leads to biopsies, I think the harm here, most of it is relatively mild. So we quantified the proportion of patients who had moderate to severe harm, and this was seen in 59 patients, so 10% of the overall cohort, which was defined as repeated CT or MRI, or any invasive evaluation, including a biopsy. Notably, only about 1 to 2% of the patients underwent biopsy. Even much of the moderate to severe harm was repeated imaging. And so this study wasn't meant to say that HCC surveillance is good or bad, but really just once again to push us to think through this individual benefit to harm ratio when we think through HCC surveillance. Most recently, we've started to try to plug the hole in terms of evaluating psychological and financial harms. This was done in a large cohort of patients that were undergoing HCC surveillance at 3 healthcare systems. All patients completed a survey at baseline, and then surveys were repeated during follow-up in patients who had any positive screening test. And then we performed this in a matched cohort of patients with negative screening tests. So you could thereby measure changes in psychological distress as well as financial harms of HCC surveillance. And then we followed this up with semi-structured interviews in 89 patients. So overall, we had longitudinal data on 38 patients who had true positive screening results, so new diagnosis of HCC, 140 patients who had false positive or indeterminate screening results, and 133 longitudinal survey measures in patients with negative screening results over time. Now, what we found is those patients with true positive results, not surprisingly, had increased moderate depression, increased anxiety, and increased financial distress. I think that strikes nobody by surprise. However, those patients with false positive and indeterminate results also had intermittent mild depression and mild financial distress that was associated with these false positive results. And so I think this highlights that those patients where we said, oh, they just underwent a single CT or MRI, the potential harm of those false positive and indeterminate results may be greater when you think through the concomitant psychological and financial impact of that on patients. Conversely, those patients with negative results had decreased depression, so there was some degree of reassurance, and there were minimal financial harms in those patients. In semi-structured interviews, patients reported surveillance-related apprehension, anxiety, and emotional distress that was present throughout this entire process, so before as well as after those positive results. And notably, patients reported variable frequency and severity of financial harms, and this was related to a combination of direct, indirect, and opportunity costs. So when we think through the financial harms, you can't just think through, is this test expensive or not? It's important to remember that patients often have to take additional time off work to come to these tests. There have to be sometimes coverage for childcare. And so there are transportation costs and there are parking costs that we think through in terms of how our surveillance and follow-up diagnostic evaluations may impact these patients. Now, for the next part of my talk, I want to focus on the different surveillance modalities and where we're going in terms of potential surveillance modalities. Now, as I mentioned earlier, we currently live in a world where we do ultrasound plus AFP. So one of the debates that had been going on for many years was, should we do ultrasound alone or should we do ultrasound plus AFP? Here we can see the data for ultrasound alone for early stage HCC detection. You can see a couple things as remarked from this figure. The first is that the sensitivity of ultrasound for early stage HCC detection largely varies between studies. You can see the sensitivity varies all the way down to 21%, all the way up to 89% across these studies where ultrasound is presumably performed in high volume expert centers, really speaking to the operator-dependent nature of ultrasound exams and the patient-dependent nature of ultrasound exams. Further, when you take a look at this across all studies, the pooled sensitivity of ultrasound for early stage HCC detection is less than 50%. It's a coin flip in terms of ultrasound being able to detect HCC at an early stage. Clearly, we need to do better. We also know that 1 in 5 ultrasounds have suboptimal visualization for HCC surveillance. Here you can see results of a cohort study looking at the visualization of ultrasound as determined by independent review of more than one expert abdominal radiologist in terms of classifying this in terms of inadequate versus adequate for the exclusion of liver masses. Once again, 20% of patients falling into likely or definitely inadequate. And notably, when you take a look at predictors of having an inadequate visualization, you can see their obesity, alcohol-related cirrhosis, and metabolic dysfunction-associated steatotic liver disease all having an association with increased poor visualization. So ultrasound, I argue, is the anti-fine wine. It's getting worse over time. As our population's changing, it's not getting better. And this was a study that we published that sort of proves that quote unquote parachutes work. You know, one would envision that, sense that poor visualization leads to lower sensitivity, although once again, sometimes nice to have a study that can quote unquote demonstrate that. And here we see a study where we looked at the association between ultrasound visualization and sensitivity for early stage HCC detection. Those patients with good visualization as determined by the LIRADS visualization score actually have pretty good sensitivity for early stage HCC, 75%. It's really those patients with significant visualization limitations where you start to see a notable drop-off in terms of sensitivity for early stage HCC of only 27%. And so these data helped inform the most recent AASLD guidelines, where we say these patients with poor visualization should actually move on to other modalities for HCC surveillance instead of sticking with ultrasound. Now, as I mentioned, one of the other debates is the benefit of using AFP with ultrasound versus ultrasound alone. As many of you are aware, AFP is the best evaluated biomarker for early stage HCC detection. We know that AFP has suboptimal sensitivity and specificity when used alone. However, the question here is more so its complementary value to ultrasound. Now, anyone who follows this literature knows that the literature is littered with editorials, review articles, commentaries about the additional value of the additional value of AFP with ultrasound. People have very strong feelings about this individual topic for some reason. On the left-hand side, you can see the totality of literature that had evaluated this as of 2018. So there are, I would argue, tenfold more editorials and commentaries, actually more than literature, evaluating the complementary value of AFP for ultrasound for HCC surveillance. When you take a look at the actual data for ultrasound alone versus ultrasound with AFP, we see that the sensitivity of the two tests alone is significantly higher than ultrasound alone, 63% versus 45%. Of course, everything has a trade-off, and there's slightly lower specificity with the combination than ultrasound alone, although the diagnostic odds ratio is higher using the two tests in combination than ultrasound alone, suggesting once again that we should be using the combination in clinical practice. These data for both benefits and harms were subsequently plugged into a cost-effectiveness model that we looked at ultrasound with AFP, ultrasound alone, and no surveillance. And you can see here at traditional cost-effectiveness thresholds, willingness to pay thresholds of 100,000, ultrasound plus AFP was the preferred strategy in over 80% of simulations. Once again, informing the most recent AASLD guidelines that now endorse ultrasound plus AFP for our current strategy. Of course, we're cognizant that the combination only detects 63% of cancers at an early stage. We clearly need to do better, but this is the best validated strategy that we have as of 2024. Now, where are we moving? Where do we think this is going in 2025, 2026, et cetera? You know, I think that there's interest in both imaging as well as blood-based strategies. So when we take a look at the imaging-based strategies, I think all of us would agree that CT is probably not a viable strategy given potential concerns of radiation, contrast injury, particularly if this is repeated over, on a semi-annual basis. Although there are data for MRI that look promising. MRI has been evaluated in a prospective study of 407 patients with Child-Pugh A or B disease from Korea, being followed over a 1.5-year period. In this cohort study, semi-annual ultrasound and MRI were done concurrently in these 407 patients, over which time 43 patients developed HCC, 32 at a very early stage and 10 at an early stage. In brief, in terms of test performance, MRI blew ultrasound out of the water. Sensitivity for early stage, 86% versus 26%. Specificity, 97% versus 94%. Test performance for MRI, substantially better than that of ultrasound. However, I think it's worth noting that this study was conducted in a majority hepatitis B population in Korea. So once again, one has to ask yourself, is this externally valid to the patients we see in the United States? And the second is that we have to consider other costs, MRI capacity and costs if we expand this to our entire at-risk population. I know at the NCI, I imagine that there's very good MRI capacity. You can get an MRI done in a very quick manner. But I can tell you at many academic centers currently, patients are waiting a couple weeks to get a diagnostic MRI. If we start doing screening MRIs, we're going to start pushing diagnostic MRIs, brain MRIs, other reasons for getting an MRI out even further. And I think we have to think through what should we be using MRIs for and what should we be looking for alternative, cheaper strategies that have increased access and capacity. And this is talking about academic centers in major cities, let alone MRI access and capacity in rural towns or smaller institutions. So I think once again, if we move towards this strategy, we have not only a potential to harm other indications, but also potentially to exacerbate disparities in HCC surveillance and early tumor detection. Now, abbreviated MRI has been proposed. You could theoretically select certain sequences, take a 45-minute diagnostic exam. By selecting certain sequences, you can shrink this to 15-minute in scanner time, and thereby may make this increased throughput, make it more cost-effective, et cetera. And early data from a test performance perspective suggest that abbreviated MRI retains some of the high test performance that we see with full diagnostic MRI. You can see here several case control studies showing sensitivity and specificity that consistently exceeds 80 to 85% across these different case control studies. However, these case control studies often compare to abbreviated MRI to full diagnostic MRI. So you don't really have independence of your test study and your reference study. And so you may be overestimating the performance of abbreviated MRI, as well as having other issues in terms of spectrum bias, only enrolling very clean cases and controls, removing questionable patients, and thereby, once again, overestimating the true test performance. Here we see a study where abbreviated MRI was actually compared to pathologic gold standard. So these are patients who underwent resection or transplantation who had an MRI that was available within a couple months prior to the surgical therapy, and looked at a simulated abbreviated MRI, once again, selecting those sequences retrospectively and comparing it to the gold standard. Overall, when you take a look at the performance of abbreviated MRI performed very well. You see the sensitivity and specificity, 88% and 89% respectively. Notably, those patients with Child-Pugh B or C disease had substantially lower sensitivity compared to those patients with Child-Pugh A disease. And this has actually been shown now in another study suggesting the same thing, that MRI may not perform as well in these patients with very nodular livers or decompensated cirrhosis. And so one of the interesting things is MRI or abbreviated MRI has been proposed as a strategy that could be looked at for patients listed for liver transplantation, sort of a select population in whom there's increased clinical consequences for HCC detection. However, these data would suggest that this isn't the answer for that population, given a markedly lower sensitivity compared to those patients with compensated cirrhosis. Now, the good thing is that there are upcoming trials that are prospectively evaluating abbreviated MRI. You can see the Fast Track trial coming from Europe, looking at concurrent ultrasound and abbreviated MRI in patients with cirrhosis. And then here in the United States, we have the Premium trial being conducted in the VA, also once again looking at abbreviated MRI compared to ultrasound every 6 months. Now, I myself am much more enthusiastic about blood-based biomarkers. I think that these have much more access and much more ease, much more cost effectiveness. And so I think that I'm much more enthusiastic about blood-based biomarkers than I am about imaging studies. When we looked at blood-based biomarkers, we're historically used to looking at individual biomarkers. Although I think there's been increasing recognition that HCC is a heterogeneous disease and a single biomarker is likely insufficient. So there's been more and more interest in multi-biomarker panels to increase diagnostic performance. This is an interesting study that looked at 48 biomarkers that were subjected to multivariate evaluation, looking at optimal 2 and 4 biomarker combinations. This was evaluated in 308 patients with HCC, about 40% being early stage, and 740 who had chronic liver disease, majority having underlying cirrhosis. When one takes a look at those 48 biomarkers, AFP and DCP, des-gamma carboxyprothrombin, had the highest C statistic amongst all different biomarkers, suggesting that AFP and DCP should form the base of multi-biomarker panels when you're taking a look at the 48 that were looked at here. Adding a third biomarker did increase sensitivity for early stage HCC, but it was agnostic to which biomarker could be added. You see any one of these 4 could be added. AFPL3, POMP, IGF-BP3, and MMP3 all had sort of that same increase in early stage HCC detection. And finally, adding age and sex further improved sensitivity for early stage HCC, and thereby you were able to get to a sensitivity of 70%. Now, it's noteworthy that the biomarkers alone, using a 3-biomarker panel, has a sensitivity for early stage HCC that's competitive to that of ultrasound plus AFP. When you use this with age and sex, you have a sensitivity for early stage HCC that looks superior to ultrasound plus AFP. So very promising data from this study. Now, of those biomarker panels, I would argue GALAD. So gender, age, and 3 biomarkers, AFP, AFPL3, and DCP, is the best evaluated and most promising protein-based biomarker for early stage HCC detection. This was evaluated years ago in a multinational nested case control study with nearly 7,000 patients, 2,400 who had HCC, 4,400 who had chronic liver disease. And when you take a look at the 2nd, 4th, and 6th row of this table, you can see that the sensitivity of GALAD for early stage HCC detection is somewhere between 60 to 80% in this case control study. And this sensitivity and specificity was consistent across different subgroups, whether by cirrhosis etiology, SVR, or hepatitis B treatment received. So very promising data from this case control study. Now, once again, I mentioned that test performance can be overestimated in case control studies, so it's important for us to have cohort evaluations, particularly among a better identified at-risk population. This was recently completed by the Early Detection Research Network in a multi-site national study in the United States, the HEADS cohort. So over 1,500 patients enrolled from 7 sites, followed for 3,800 person years. And you can see over this time, 109 developed HCC. When you take a look at GALAD at this threshold, GALAD actually was able to detect HCC prior to diagnosis in 65% of patients with a specificity of 82%, substantially better than the performance of AFP. These data, once again, look competitive to that of ultrasound plus AFP when one takes a look at GALAD, a biomarker alone. Now, these phase 3 data have informed this phase 4 study, which just recently launched this past couple months. Here we can see a national trial that's being funded by the NCI amongst patients with cirrhosis or chronic hepatitis B. 5,000 patients with Child-Pugh A or B cirrhosis or chronic hepatitis B who will be randomized to ultrasound plus AFP or GALAD alone. These patients will be followed for 5 years, and the primary endpoint of this phase 4 randomized control trial will be a change in the proportion of patients found at an early versus late stage. The hope is that we can thereby, if we hit the primary endpoint at year 5, the hope is that we can convince the Early Detection Research Network and the NCI to continue following these patients for another 5 years, where we can then evaluate downstream outcomes, including mortality. Now, the data I've shown have largely been focused on protein biomarkers. I think as many of you know, there's been a lot of interest in liquid biopsy, looking at different liquid biopsy techniques, whether circulating tumor cells, methylated DNA, EVs, et cetera. I think from a surveillance perspective, the best evaluated strategy has been methylated DNA panels. Here we can see results from a phase 2 study, a case control study of 156 HCC cases, 245 controls, vast majority having cirrhosis, looking at a methylated DNA panel. And in brief, what we see from this methylated DNA panel is a very high sensitivity for early stage detection, 82%, and a specificity of 87%. Significantly better than AFP and non-inferior to that of GALAD in this case control study. And this methylated DNA panel is now moving on to a subsequent prospective evaluation in a cohort study, looking at, once again, patients who have underlying cirrhosis will undergo ultrasound and then have the methylated DNA panel, which will then be compared to CT and MRI in all patients. This study is ongoing, and we hope to have these data soon in terms of evaluation of this methylated DNA panel. Finally, there's also been early work looking at cfDNA fragmentomic analyses. So not looking at specific mutations, but looking at alterations in DNA fragment size being followed in the blood, with an expectation that you would have smaller fragments found in HCC cases than those patients with underlying cirrhosis. This is a study that was published this past year, small numbers, but showing very promising area under the receiver operating curve and having very high sensitivity and specificity for early stage HCC. Once again, promising data that I think needs to be better evaluated in larger case control and cohort studies moving forward. As I mentioned, these strategies are promising, although need to be better evaluated, both in retrospective cohorts as well as prospective cohorts. We're starting to see this happen where both abbreviated MRI and GALAD are now undergoing phase 4 evaluation at this time. We were fortunate to be funded by the Early Detection Research Network, where we have a clinical validation center that is building infrastructure for further validation of these promising biomarkers. And so we anticipate hopefully seeing expedited validation of these biomarkers over the next several years. If you know of anyone who's looking at promising biomarkers for early stage HCC detection, please let us know. We're happy to work with anyone in terms of pushing these biomarkers forward. Finally, over the last couple minutes before I take questions, I just want to mention another important topic here. When we think through surveillance effectiveness, I think it's important that we remember that surveillance effectiveness is not only driven by test sensitivity, but also adherence. A test doesn't matter how well it works if it's never used in clinical practice. And you can see here some simple math of, on the back of the envelope, where you can see that test adherence is equally important to test performance when you think through effectiveness in clinical practice. And we know that this is important because HCC surveillance is underused in clinical practice, shown in many different studies, both in the US as well as ex-US, showing that HCC surveillance is unfortunately used in a minority of patients. And this is related to barriers across the entire, once again, spectrum of how you have to do this, both from a provider and patient perspective. When you think through providers report multiple different barriers, including lack of knowledge, insufficient time in clinic, and competing concerns. And so here we know that there needs to be a thought for different barriers, different interventions, including best practice alerts or outreach strategies where one can do this on a population basis if we want to address this from a provider perspective. And from a patient perspective, patients report multiple different barriers, including costs, difficulty with scheduling, uncertainty where to get the ultrasound done, and transportation. And these barriers were associated with lower surveillance utilization when one looked at chart review. Notably, I will put out there that many of these barriers, including scheduling, uncertainty where to get it done, transportation, are unique to imaging. And so if we move to blood-based biomarkers that can be done on the same day as a clinic visit, you may not only increase test performance, but may increase adherence, thereby markedly increasing effectiveness. And finally, patient adoption may be greater for these alternate surveillance strategies. This was a study where we did a conjoint survey study looking at these different factors that are attributed to these different surveillance strategies. And patients, when you take a look at this, value surveillance benefits, logistics, and the potential financial harm. And when you overlay this, patients prefer MRI or blood-based strategies strongly to ultrasound with or without AFP. And so if we do this, we may actually increase patient adherence and adoption compared to ultrasound plus AFP. I'm going to skip the details of this slide, but I just want to put out there that there have been multiple interventions that are efficacious to increase HCC surveillance, whether it's simple like patient and provider education, best practice alerts, or more intensive interventions like mailed outreach. But all of these interventions have been effective, and I think we now need to think through how we apply this in clinical practice. And so during my last minute, I just want to come back to my vision of precision screening. And so once again, thinking through moving away from a one-size-fits-all strategy and thinking through tailoring of which strategy we can apply to different patients. These are results from an ongoing cost effectiveness study that we're planning to submit in the next week, where we have looked at what if we looked at the test performance, understanding these tests don't work the same in all patients, as well as differences in terms of risk, stratifying people into low, intermediate, and high risk, and thinking through, for example, that ultrasound works better in skinny individuals than it does in obese individuals. It works better in viral patients than non-viral patients. And so if you overlay this, you may be able to, albeit more complicated, you may be able to individualize which test is best for the individual patient we're seeing in front of us. And here we show that this is much more cost-effective compared to our universal one-size-fits-all ultrasound plus AFP strategy that we have at this time. So in summary, HCC surveillance is supported by a large randomized trial in patients with chronic hepatitis B, several cohort studies in those with cirrhosis. Test accuracy and surveillance utilization are both key factors when we think through effectiveness. Ultrasound, albeit the best test we have right now, has suboptimal sensitivity. We need to do a better job of really pushing forward these emerging and promising blood-based and imaging-based modalities. And surveillance is underused due to a combination of patient and provider barriers, although we have promising interventions that can increase utilization. And so hopefully we can move forward from a one-size-fits-all, thinking through how we can think through both emerging modalities as well as interventions to optimize surveillance for the individual patient in front of us. With that, I'd like to thank all of the collaborators I've had the fortune of working with, and obviously thank the NCI, who has been very generous with funding over the last several years. And then, of course, thank my family, who forgives me for giving as many talks as I do. Thank you, and happy to take any questions.
Thank you so much. This is a really truly fantastic talk. And even though I sort of familiar with this topic, but particularly, obviously, there's so many data. I just want everyone to know that we have recorded this talk, and that many of you want to go back to read more information because there's so many information there. You will have a really pleasure to read later on. So I'd like to just open for question. We have still a few minutes for question. If and one of you would interested to raise question, please open your camera and then raise hand.
So maybe let me start with one. I mean, I can only echo what Shin said. You think you know this topic and you realize you have no clue after listening to you. But I actually have one point that you have not addressed.
Okay.
And that's the following point. In terms of fatty liver disease and obesity, HCC may actually not be the patient's largest risk to die of.
Yeah.
Okay. Obviously, there's a high risk for cardiovascular disease. Now, and I have no idea how to do this, but this is just an idea I have. So if you actually have these patients and you bring them to a physician and do tests, you may actually, find other events, non-HCC related, which are, beneficial for his health.
Yeah.
Whatever, cardio, new diagnosed hypertension or something.
Yeah.
So what do you think about that? And that you will miss if you only do blood tests.
Yeah. Yeah. So Tim, a couple of things. The first is the blood test still would be paired with a clinic visit, right? So you're still having the patient see the provider. And your point is well taken. And it's something that, we just had this discussion. It's funny you bring this up. We literally just had this discussion this last week, that this is actually one of the other potential benefits of surveillance, whether that's blood, imaging based, et cetera, but it's hard to quantify. You're engaging that patient in care. And so you almost want to strike this optimal balance of patient anxiety, this healthy anxiety about their liver and their sort of underlying liver disease and risk of cancer, where they become engaged in care, but you don't want to cross this border in terms of unhealthy anxiety, where they then check out. And so, I've talked about trying to think through how you could measure that. How do patients' engagement with the healthcare system change after they undergo surveillance, whether good or bad? The issue with HCC compared to other cancer screening programs is that you have changes in their liver function. And those are more likely to drive that patient's engagement in healthcare than HCC surveillance. So the confounding factors for HCC are too great for me to, at least for me, to wrap my mind around how I could come up with a good analysis. Although your point is well taken, and this has been shown in other cancer screening programs where healthy engagement in cancer screening can change how people engage in other preventive behaviors and cause a healthy interaction.
Very good. Yeah, I think we have several additional questions. Unfortunately, I have to leave for another meeting. So may I ask Tim to continue with the Q&A? I think this is a really fantastic talk. I have a question, probably going to email you.
Okay.
I think it's something to do with the perceived stress. I think that might address something to do with the potential harm and the issues in the study. But I have to leave now. But I really
okay, I take over. So I see Alejandro put his camera on. You have a question?
Yeah, I have 2 questions. Can you hear me?
Yes.
So first question is, when the ultrasound or blood-based tests are done, is the possibility of cancer at non-liver sites considered? And if so, do you adjust the sensitivity accordingly?
Yeah. So, ultrasound typically is just the liver ultrasound, so it would not have that same ability to detect cancers elsewhere. Although we are currently looking at this in terms of patients who have an ultrasound, then go on to receive, for example, a diagnostic CT or MRI, there are incidental findings that you can detect on that diagnostic evaluation. We previously published one small study about this that we found actually a reasonable number of patients who have incidental kidney cancer, incidental pancreas cancer that are found sort of during this evaluation. And so there can be some of these patients who are found. When you take a look at blood-based biomarkers, many of the protein biomarkers are relatively specific for HCC. Although when you take a look at methylated DNA markers or particularly multi-cancer detection platforms, obviously there's an increased likelihood that you'll pick up non-HCC tumors from those panels. Is that answering your question, or were you asking?
Yeah, something? I mean, I guess part of my question is there a cost effectiveness to liver specific blood-based tests rather than multi-organ blood-based tests?
Yeah. So, it's a good question. And so when you take a look at other cancer screening programs, those are typically done in general populations, right? So colon cancer done in everyone over the age of, 45 now, breast cancer done in older women, et cetera. But here you don't have that broad population. You really have a cirrhosis patient population, and HCC surveillance is not cost effective in non-cirrhotic patients. And so I think here, because the target population is so different, I think it is helpful to think through liver-specific, surveillance strategies.
Okay, and my other question was, if you succeed and let's say the detection of early-stage liver cancer in the USA could be doubled, would the impact on the workload of liver surgeons and other medical specialists be increased or decreased?
Yeah, I mean, so, you're right that there would likely be more surgical therapies. But right now, I would argue that, honestly, liver surgery is uncommon in the US. So it's not like we have a sort of an issue with workforce on that side. I think we'd be perfectly fine in terms of increasing, early detection and surgical therapies. One would have to think through liver transplantation. Liver transplantation is sort of one of the major treatments, and more than workforce, you're really talking about liver grafts and the number of grafts we have available for liver transplantation. Although in parallel, there's a lot of strategies in terms of using quote unquote marginal liver grafts and rescuing them to increase graft supply. So I think that those issues are being solved well in advance of our ability to increase early detection.
Thank you.
So there's another question in the chat about Helicobacter pylori, and apparently there's a study that showed positivity association with HCC, and if you have any comments.
Yeah, I don't know that study. I haven't read that study, so I don't know if I can remark on anything truly there. I'm just trying to think through this real time. I don't know. I'd have to read the study to see what they adjusted for. We know that H. pylori can be associated with many other factors, including socioeconomic status, race, ethnicity. And so I would need to see that study to see if they fully adjusted for concomitant risk factors that also tend to cluster in those same populations, viral hepatitis, fatty liver, et cetera, to see, how truly causal we think this is. Obviously, the causal link between H. pylori and gastric cancer, easy to draw there, but I'd have to read it to see any truly potential causality from H. pylori and HCC. I don't know, Tim, if you've seen that study, if you have thoughts.
No, I don't.
Okay.
And then there's a last question, and I don't know, that's a little bit difficult. Liquid biopsy companies looking to develop tests for detection of cancers, and they continue to proliferate. And what do you think? Can these organizations properly investigate the value of their solutions, including analysis of potential patient harms?
Yeah, great question. And, I think I know the NIH has funded their network in terms of looking at sort of these liquid biopsy strategies. And I think that's actually, making sure that the NIH is involved in sort of trying to guide those evaluations is, I think, the first key step here. And I think that what I would say is that I think it is important, and I know this is an easy answer here, and maybe too simple of an answer for this complicated question, is I do think that the value needs to incorporate potential patient harms. When I have talked to these companies in terms of multi-cancer detection, that has been one of the things that I have really harped on, and then they stopped talking to me because I harped on it too much. I think it's highly concerning when you have a patient that has a multi-cancer detection platform test that is positive, they undergo diagnostic evaluation, they're not found to have any cancer, and then you tell them, well, don't worry about it, your diagnostic evaluation was negative, but you're really telling the patient, we saw small fragments that suggest you have, DNA of cancer in your bloodstream. And I think that's different than a protein biomarker false positive. And so I think evaluating the psychological harms of these multi-cancer detection platforms, particularly for those that you can't locate, you can't actually say a site of origin. I think that the financial harms of prolonged, repeated diagnostic evaluation is real. And the potential psychological harm is immense. I mean, it's almost like hearing your death date, but not knowing how to solve it. If you have a multi-cancer detection platform test that's positive, but your diagnostic evaluation is negative. So I think they're incredible in terms of potential benefits, but also incredible in terms of potential harms. I don't know what's more scary, that or social media or AI, but all three are scary.
All right. I think, we're 8 minutes past the hour. I think, this was a great last word. And thank you, Amit. You can see, I think we learned a lot. We had a lot of questions. Thank you for your time. And thanks, everybody, for joining our seminar today. Have a good day.
Thank you.
Bye-bye.
Thank you. All right, Amit, we'll